hello. Day 3 of the American Heart Association Scientific Sessions. I'm excited to be joined by my Vice Chair of Programming, Amit Khera. This is going to be hopefully a review of today, but maybe some big thoughts on how the meeting's been going first. Amit, maybe I'll start off with you. What are the themes you've seen over the last 3 days here at a scientific session?
Sure. You know, the third day is always sort of that day where there's still a lot of science going on and, till the end, but it is a time of reflection on sessions. And I think, the big thing to me was just getting everyone together again. And the reason that's important, I love going to the poster halls and seeing sort of the early career folks come in, because if you think about it, they didn't have this for the last 2 years. This is new, and I think those connections, presenting their science. I got to go to some Young Investigator Awards. To me, that was sessions, as well as the early career and fit lounge. That's where some of the best programming was about career and career development for our future scientists and physicians and healthcare practitioners. So I really loved all of that, in addition to everything on the main stage. What about you?
No, I totally agree with you. I think the biggest theme for us might have just been, we called it Welcome Home, and it felt like home. And I think the second thing is there was a lot of rejuvenation, energizing. Even though these meetings can be busy and tiring, like the energy to feel the science or actually understand the things people are doing. So that was good. And then there was the science. I don't want to underpin the science. There were nine late-breaking sessions, 9 featured science. Today in the featured science session, strong heart failure, pretty important study, published simultaneously in Lancet. Randomized trial of sending people home in usual care versus guideline-directed medical therapy and rapidly escalating them onto guideline-directed medical therapy, and significant reductions in cardiovascular events and hospitalization. So certainly a roadmap on what we should be thinking about for heart failure, a very common issue. Today also I was in the first session. I got to tell you, kudos to our investigators and the patients that participated in the BEST CLI trial. Just to remind everyone, that was best endovascular versus best surgical therapy for patients with critical limb ischemia. That took about 1,800 patients, 1,400 were in cohort 1, patients that actually had a venous conduit that was usable. In patients who had a venous conduit that was usable, it looks pretty clear, at least looking at the trial data. We're going to have to see a little bit more about the patient characteristics, that if you could get the surgery, you had less amputation, you had less repeat interventions. One of the striking thing about that study population, we knew this, but the arm that did better had an event rate at 2 years of 42%. Just let that wash over you if you think about people that are having event rates, right? It's sobering on things we could do. In that trial, in the late-breaking trial, there was also some therapies around COVID and thromboembolism prevention. A randomized trial from Greg Piazza looking at discharge to 35 days of 10 milligrams of rivaroxaban to see if that prevented people from having all thrombotic events. Unfortunately, as the trial was going on, we got lesser rates of COVID and people got better, and maybe the risk wasn't as high. So some signals, but no significant difference. But another piece of data in that space. And then Alex Baropoulos presented a study on called Improve, where they used actually clinical decision support, got people on more antithrombotic therapy correctly. At discharge, got more people on antithrombotic therapy, and saw signals for reduced events. So actually, implementation. How about you? What did you think about the electrophysiology?
Right. Well, listen. First, I think you brought up practice-changing studies today. We heard Strong HF, Best CLI, many others, and EP saved the best for last. I guess we're on the last day. And some great EP studies. Progress AF. So. We keep having this debate about where's catheter ablation is the first line. So catheter ablation versus antiemetic drugs. It seems like catheter ablation may have been the better option, and we're moving along that continuum. From there we have a novel agent now, right? Intranasal calcium channel blocker for individuals that have arrhythmias. So can you imagine that being at home? And intranasal, it was pretty marked reduction in SVT time, if you will. And then, something that's really come up over and over again is shared decision-making, right? And so, with our AFib studies now looking at also shared decision-making tool that providers and patients can use to enhance the ability. It's very confusing about anticoagulation. So we love these practical tools that we're getting in trials as well. So great day from EP. And then, last but not least, really, is actually this hypertension session.
Yeah, so, we have had 2 late-breaking sessions on hypertension, one today on resistant hypertension, and had 3 studies, randomized trials with drugs for resistant hypertension, and then also the 6-month follow-up of Spiral on Med that Dr. Canzari is presenting. So again, the take home for me on those is talk about a problem that's still significant. Estimated somewhere around 11 to 13 million people have resistant hypertension, being on 3 drugs with at least one of them being a diuretic. Well done studies, different agents, trying to get to the finish line. One of them that was interesting, a drug called Bactristat that was actually stopped early in phase 2 because of an 11 millimeter reduction or an 8 millimeter reduction depending on the dose for people with resistant hypertension. Going to have to see how that gets through the regulatory process, but another opportunity. I'll contrast that to DCP, which we heard on the day one, which is hydrochlorothiazide versus chlorthalidone. I actually think there, talk about escalate dose, get to the next agent, escalate dose, get to the next agent, instead of making as much switch potentially. So I think we're learning a lot more about how to take care of patients with hypertension. So a great session, and I'm sorry I didn't even think about the interventional one. What's going on with me? Yes, so Spiral said that we found that in the early run-in phase of those 80 patients, there was significant reduction. When they went out to 6 months, they don't see as much. During the time of COVID, it was hard to get ABPIM, so we're going to have to see that data some more. I still think when you looked at the cleanest data on and off, you're going to see some signals, but in the field of now drugs and devices, we're going to have to make shared decision making, just as you said.
No, I'm glad we had two sessions, plus also the first one with HCTZ and clozalidone, that so much focus on hypertension. We know, from the Heart Association that hypertension is such an international focus, and we're still not doing well. So to have new agents and new ways of treating blood pressure is so important. So, well, it is the end of AHA Sessions 2022. This is always bittersweet, right? So the good news is these conversations will keep going. So we keep learning. We keep having more conversations about things that we just are hearing the first few minutes of, and we'll have to have ongoing discussion and implementation. But guess what? Next year in Philadelphia. So we look forward to seeing everyone for AHA 2023 in Philadelphia. We'll see you there.
See you there.